Hi Ellen, are you alright?
Hey, I'm good, thank you. How are you?
Yeah, good, thank you. Are you having a nice Sunday?
Yeah, it's not too bad actually.
Yeah.
Just a chilled one, really. Not much else we can do. How about you?
Yeah, pretty much the same. I do need to get outside today, but just not got around to that quite yet.
Not
It
yet.
started to really tinily snow though.
It's like the smallest flakes, isn't it?
So
Trying. It's trying.
yeah, it's meant to be freezing tomorrow. I'm really not looking forward to that. Anyway, yeah, so do you just want to give a little bit of an intro on kind of where you're based and which specialism you're on, and then we'll kind of dig deeper.
Sure. Yeah, sounds good. So I am currently training for the critical care STP, and that's at Papworth Hospital in Cambridge. People normally know about its much more popular neighbour, which is Addenbrooke's, but Papworth is a specialist heart and lung hospital, which is just next door to Addenbrooke's.
That's cool. I feel like I've seen Royal Papworth on hospital and stuff like that on BBC.
Yeah, we had a series filmed, I think it was last year, Surgeons at the Edge of Life.
Yeah, that was
where
it.
they did a lot of the procedures and stuff on there, which was really cool. It's really weird seeing people that you work with now on the telly as well. Like, oh, look, it's so-and-so.
That's mad. Yeah, it was insane. I honestly cannot believe those programs. I love watching them.
Guilty pleasure, even though I come home from work and it's just like watching work again. I still love it.
Yeah, cool. So yeah, I guess your specialism must be pretty crazy at the moment, but I also have the feeling that critical care in healthcare science is usually quite different to critical care on ITU. I don't know if that's true.
Yeah, so it is very busy at the minute. So with us being particularly a respiratory centre hospital, we've had a lot of COVID patients in. We also run as a hospital a service called ECMO, which stands for extracorporeal membrane oxygenation, which is essentially if somebody needs the highest level of support for COVID, it's a machine that works for your lungs. So it basically takes the blood out of you, oxygenates it, and then pumps it back in. So it's quite an invasive procedure. We're one of, I think it's 5 or 6 hospitals in the country that do it. It's quite a high in demand service, so we've been kept especially busy with that. We're kind of we're known for our ECMO services, so it really is the highest support you can get when someone's deal with COVID. So we've been really busy with that. In terms of what you see in ITU, I guess the environment that we work in is very similar to what you can see on the news at the minute. Papworth in particular, a lot of on the East Anglian news, just because, like I said, we're known for the respiratory support. So a lot of people have heard of us now, whereas before, probably not many. But yeah, it is very much what you see. We work really closely with the doctors and nurses. We're quite a patient-facing specialism, so it means that we get really involved in the bedside care of the patient, which is a really great opportunity. But at the minute, it does mean that our workload is slightly increased than usual. Normally, we tend to work with patients that have either had an organ transplant, so for example, they've had a new heart, or they've had a new pair of lungs or a singular lung. And in their kind of recovery, we do a lot of kind of scanning of the new organ just to see how it's functioning, and we can do those sort of tests. But at the minute, our work has been primarily with the COVID patients, so it's been an interesting experience for sure.
Have you been redeployed then, or have you just kind of been moved across onto a different side of critical care?
So as a critical care scientist, I suppose our normal roles would be, like I said, scanning. We set up a lot of the monitoring equipment that's kind of next to the bedside. We also prepare ventilators, that kind of thing. So I suppose that part of our role hasn't changed. We still do a lot of that, but we should be on rotations at the minute. And we've kind of been called back from our rotations to help out in ICU. So it is a redeployment in terms of we should be in other departments at the minute, kind of getting a better understanding of the critical care patient from sort of a cardiology perspective or a respiratory perspective. But we've also undertaken a new role, which is as a bedside carer. So the best way I can liken this to is being a makeshift nurse without a nursing degree, a fraction of the knowledge that our amazing nurses have. But yeah, a different role. It's not what scientists would usually do. It's kind of hourly obs and that kind of stuff, just to try and lift the burden for the nursing team a little bit. That's our kind of redeployment, but we're still in critical care. So
yeah, I guess, is the team that you've been working with the same team that you would have been working with before? Are you still seeing the same kind of faces?
Yeah, so we're still most of the same faces, but a lot of people have been redeployed as well. So it's nice to be able to work with loads of new people that are new to critical care as well, which kind of makes me feel better as a first year trainee, because I kind of feel like I'm not the only one that isn't sure about certain things. And if people know about it, it's usually because they were there for the first surge, so they've kind of got extra experience and they can help me as well, which is really, really beneficial. So yeah, we've got loads of people. All the different cardiac physiologists have come to work with us, and theatre porters, and just everyone's kind of chipping in to help out, which is really nice actually.
Yeah, my mum's been redeployed at the hospital that she works onto the unit as well, but she's normally like an ADP.
Oh right, okay, yeah. Theatres are pretty quiet at the minute, so
yeah. I think there's like a skeleton team of people that are needed, but everyone else has had to move across.
Yeah, everyone seems to kind of be on call more than they would usually now. Just kind of be there in case there's an emergency, but apart from that, go and help the others. So.
Did you get much of your cardiology rotation then, or was it kind of straight through?
So, yeah, my cardiology rotation was supposed to it did start in January. I was there for 2 weeks, and luckily it was quite a jam-packed 2 weeks. So when I should have had 8 weeks, but I managed to cram quite a lot into the 2 weeks, sort of suspecting that the move back to ICU was going to come sooner rather than later. So I was quite lucky in that everyone was kind of understanding that as well. So I got loads of opportunities to get involved in different things. So I managed to get quite a bit done in a short space of time. But I'm sure once this is all over, we'll have the opportunity to go back and just kind of tie up the loose ends.
Yeah. So. I bet you're learning like so much quicker than maybe you would have done in like normal circumstances as well, just because of the volume of workload you've got.
Definitely, yeah. I had no critical care experience before applying to the STP. And I don't think, it's hard to say there isn't a better time to be a critical care scientist, but in terms of getting involved and getting stuck in, now is, it's non-negotiable. So, you really do get so much experience, so much knowledge, being able to work with so many different people as well, and everyone's really willing to help, which is great. So
that's really good.
Yeah.
Are the patients that you would work with normally then, are they kind of awake rather than asleep?
Really,
words.
No, that's pretty accurate, to be honest. That's what we would call them anyway. So it's a real mix. It depends. A lot of time spent kind of pre-COVID, we look after people that are kind of immediately post-operative. So they come out of surgery whilst they're still asleep, and you tend to kind of see the progression of them kind of coming around from their sedation, waking up, realizing that they are intubated, so they have a tube in their throat, and that horrible discomfort when someone realizes they're awake but they're still not quite with it. And then we kind of see them progress from critical care back to the ward. Whereas now with our COVID patients, it's a lot kinder to the person to kind of keep them medically asleep. Just gives their lungs the best opportunity at recovering if they're not doing any work themselves and you've kind of got the machines going for them. So most of the time it tends to be they're asleep at the minute. But we're always going to have our emergency cases where it is just a quick stent put in the theatre or the cath labs, and they tend to be our kind of, they've only been asleep for a little amount of time and then you wake up with them kind of thing. So
that's nice. It must require like a really different set of communication skills then, if you're having to kind of alter how you're communicating with them as they wake up.
I think I've definitely realised how much you can communicate with somebody without talking. That sounds really silly because obviously you're the one that's going to be the talking, but you have to be so receptive to any kind of movement, any sign that they're giving you in terms of when you're like asking for their consent to, I don't know, even do small procedures that
Yeah.
they will need. You just have to take any kind of sign. So we use a lot of eye contact and just making sure that the person's following what we're saying, head movements depending on what kind of situation they're in, and just silly things like, oh, if you could just squeeze my hand if you can hear me, those kind of things. And it's taking it right back to basics, because you can't have a conversation with a lot of our patients for obvious reasons. So you have to just be a bit adaptable with that. But yeah, it's been a massive learning curve. It's something I didn't quite anticipate before starting critical. So, yeah.
What was your background before the STP? You said you didn't have any like direct critical care experience, but
yes. So my undergraduate degree was actually in medical physiology, which I was really grateful for because it kept my options quite broad. I liken a degree in medical physiology in learning a little bit about a lot of things. So there were so many different routes I could have taken after that. And I saw that the STP applications were open in January, and I thought, I'm just going to go for it. So I applied for 2 completely different specialisms. When applying for 2 was a thing. Obviously, I know they've cancelled that this year. So I applied for critical care, and I actually applied for cancer genomics as well, which they couldn't be further apart.
Yeah. I know a few people that have applied for something and then also applied for cancer genomics. It seems to be one that like a lot of people kind of put as a second.
Yeah, definitely. So critical care, just because I was really interested in it, it was something that I didn't know much about, and I was really keen to find out more. I was also a first aider at uni, so I kind of found that I was able to deal with relatively unwell people and remain calm under that kind of pressured environment. So I thought that's going to stand me in great stead for the situations, even more so because in ICU you can pretty much predict who's going to come in, whereas if somebody collapses in front of you, you can't predict that. But yeah, cancer genomics I picked because it was related to my dissertation topic at uni, which I was really interested in. But so I got an interview for critical care, but I didn't for cancer genomics, and I think that worked out for a reason now, because I'm not sure it'd be a specialism that is quite what we're doing now. So
yeah. It's also really not patient facing too, so if you want that kind of patient communication, genomics is not the one to go into.
Definitely, yeah. I think I've seen a lot of people kind of doing like telephone consultations and video consultations, which to critical care is completely alien because you've got the person right in front of you. So
yeah, literally. We just get the samples. You don't actually see the person on the other end very often. Cool. So it sounds like you kind of fell on your feet then. It's really interesting that you're a first aider with uni. Was that just in your department, or was it within the whole uni?
So it's just started off as an extracurricular activity, really. I started going to the first aid society on like one evening a week, just learning first aid to start with, and then I did my qualification through the society, and then that was in my second year, and then in my third year I decided I wanted to be on the committee and start teaching people first aid. So I kind of got into that, and then I just thought, yeah, you know, I was always interested in what goes on inside the body anyway with the physiology degree, but that was something I hadn't really kind of explored before. A physiology degree, we got taught everything that should happen in the body and then what happens when it doesn't, whereas first aid, it can come out of completely nowhere, and I kind of enjoyed that kind of investigative, being a first responder kind of environment. So I thought, yeah, I really want to work with patients, and definitely in a hospital setting.
That's so cool. I went for like a first aid training course thing with, is it St. John's Ambulance, I think?
Yeah.
Just, I worked with kids, and it was mad how much you kind of have to think about in one setting.
Yeah, there's a lot going on, but it's been really interesting actually, kind of doing like advanced life support courses now in hospital, and just realizing how different it is if you're out on a playground versus in a hospital setting, and just how different it is. But yeah, it's been really interesting and good skills to have as well. So
did you use it in your application much?
Yeah, I did. I sort of spoke a lot about effective communication skills and how that's vital. I had no idea what sort of patients I'd be communicating with whilst I was in critical care, but I definitely honed in on the transferable skills that first aid kind of gave to me, especially talking in front of a lot of people and teaching. Found that really, really helpful, because a lot of, obviously, you understand what we do with the STP is kind of raising awareness of healthcare scientists within the NHS. And it does require us to talk to a lot of people and in front of a lot of people sometimes too. Maybe not in COVID times, but it will do eventually. So yeah, I just think it was a really great experience to have, and I'd recommend it to everybody. And I think it just kind of shows first aid is one of those things, it's such a vital skill to have, and just showing that you're committed to learning new skills like that is obviously something that any employer would look for, let alone healthcare. So
definitely, that is very true. Have a lot of other, I don't know if Papworth takes maybe like cardiology trainees and stuff like that. Have a lot of other trainees kind of been moved over into critical care with you, or?
Yeah, so Papworth take critical care scientists, they take cardiac scientists, and they also take respiratory scientists as well. So we've got a nice little network. There's only 7 of us, but we're a nice little group. Yeah, and they've all been moved over in kind of waves in terms of they've tried to keep rotations as normal as they can, but a lot of our rotations really heavily rely on outpatient appointments, and obviously they haven't been happening recently, and they've kind of been postponed or moved online, so we can't get as involved as we'd like to. So it's been nice getting to know the other STPs in terms of they've come to critical care, and they wouldn't have normally had a critical care rotation. So it's nice for them to kind of get the experience that they otherwise wouldn't have had. We can teach them a little bit, and equally when they've got some spare time they can talk to us about cardiology and respiratory. Which is really good.
That's true. Learn like together. Do you have another trainee with you in critical care, or are you the only one?
Yeah, there's 3 of us actually, so we're a nice little trio. We travel as a pack. Yeah, and it's really nice actually. We've all had relatively different backgrounds in terms of coming to the STP, but it's really nice just to all start on the same kind of platform again and like work together. It's been really great actually having the other 2. We've all kind of bounced off each other for ideas for various things and just been able to help each other, especially while we were on different rotations. So my training officer was really keen to kind of split us up, one so she didn't have 3 of us kind of following saying what can we do, but also so we get to see different things at different times. So it's been really helpful. Really.
Definitely. That's cool. I just had something in my head and it's completely gone.
Oh no, sorry, I probably won't.
No, it's okay. No, it's fine. So that was it. In 2nd and 3rd year, do you do any like pediatric care, or is that a completely separate thing? Do you just focus on adult?
Yeah, so Papworth is an adult only hospital.
Okay.
I know in Southampton and Manchester they do have pediatric units. I'm pretty sure they do anyway. I'm sure I've heard the other girls speak about that. So we don't directly get the experience at Papworth because the youngest person that we'll have is 18, 17 at a push, depending on kind of their clinical history. But we will get the opportunity to rotate to. Oh,
sorry, drop my pen.
No, don't worry. Yeah, we'll hopefully get the opportunity to rotate around different ICUs to kind of see what's going on. I know they're taking some trainees in London for the first time this year in the 2021 intake. So I think the plan is that we might go and visit the new trainees in London, kind of see how they're getting on, and then also get some pediatric experience as well, and as well as some neuro stuff. We don't tend to deal with anything kind of this way up. We tend to just stick to the chest. So yeah, it'd be interesting to kind of see how different departments work, and especially how their kind of specialties direct the care that they give. So
definitely. So are your rotations then going to be in cardiology and respiratory and then critical care? Are those the 3 that you do, or do you do another one?
So they're the 3 main ones. We also have a rotation called, I think it's called device risk.
Oh, yeah, and management.
It's medical devices. It's a fancy name for medical devices. So we spend some time with the clinical engineering team. So we get to kind of see the procurement of new equipment, which has been especially interesting at the minute for things like ventilators. You know, everyone now kind of understands the process and how long it takes to actually acquire a new piece of equipment. So I think that'll be really interesting to get that rotation when they get resumed again. And you learn sort of about the life cycle of a piece of equipment, and say it gets broken, how long it gets decommissioned for, and that kind of thing, which isn't kind of something we'd tend to do day to day. You know, we're not engineers, we're kind of, well, we're physiologists at heart, I guess. But it's really good to understand the equipment that we work with, because obviously critical care is such a equipment heavy department. We really heavily rely on the machines that we have, and having a good understanding of them probably does start in terms of how do you get one, and what happens when it goes wrong. So yeah, that's our fourth one, and then there are kind of main points of call.
Okay, that's really interesting. I've not actually, I saw it on the list, but I had no kind of idea of who did it.
Yeah. Yeah. See, none of us are physicists as well, so it's quite interesting going into the clinical engineering and seeing all these different tools and things. And obviously you've got to understand the basics, but when it comes to physics, it really is a world of its own. So hats off to anyone who's doing medical physics.
Especially with the scans and things like that, I guess it's good to get a bit more of a background understanding of how everything works.
Definitely, yeah. I mean, we do so much ultrasound scanning in what we do. That's everything from visualizing a vessel that we're going to put a cannula in, or just generally scanning the heart and seeing it does use ultrasound. And it's one thing getting the probe in the right place and knowing what you're looking at, but if for some reason the probe doesn't pick up what you expect it to, kind of why is that? Is that a patient problem? Is there something there that shouldn't be, or is it the fact that your probe's upside down? That would make a difference. So yeah, it's good.
So with people coming from transplants and things like that, are you involved at all in any of the preparing for the surgery and kind of scanning them pre-surgery, or is it all post-surgery patients that you work with?
So generally in ICU, we don't tend to see patients until after they've had their procedures, but a lot of work goes on in outpatients for the preoperative assessments, and that's something that we get to join in on whilst we're on rotations. So if somebody's having a heart transplant or a lung transplant, they might come into the respective departments and do kind of lung function tests before you do the surgery, so you can just kind of weigh up someone's kind of preoperative risk, and you can kind of make the decision in terms of will they be fit enough for a transplant, full stop. Because there's a very big difference kind of having an emergency transplant for people that this is kind of their last option in terms of a treatment pathway, or someone that you can kind of preempt that their condition's going to get worse, so you'd rather transplant them now rather than later. And you can do a lot of tests and find out. It's really interesting, actually. You can kind of preempt someone's post-op ICU stay using those tests, so you kind of know what you're going to be dealing with before they've even had the surgery. So it's really clever. But yeah, we don't kind of, as a critical care scientist, not something we'd massively get involved in. But in terms of as a trainee, where we get to paint the whole picture, it's definitely something that we'd get involved.
That's interesting. How was uni? Have you had all of your teaching, or have you still got some more to go?
Yeah, so ours is a bit funny, really. We kind of get 6 weeks in the first year, and that was kind of October to mid-November. And then we don't actually go back to uni now until second year for 3 weeks, and then third year for 3 weeks. So we're quite light on the ground in terms of teaching. The coursework makes up for it, though. They give us to do. So yeah, it's good. I found uni from home the weirdest thing. I didn't quite anticipate how difficult it would be, to be honest. It sounds like you're sitting in your bedroom for 6 weeks, but it's not.
It's so hard, because once you've made the fatal mistake of being like, I'll just do this lecture in bed, you're ruined.
Or no, I'll watch this one later, and you just never do. Never do. There's some now, and I think, if I'd not been in bed while that lecture was going on, maybe I'd understand it a bit more.
Yeah, literally. Because we had Introduction to Healthcare Science or something like that. That was one of the modules. One of the lectures was genetics, so I was just like, right, I'll do that one later. I know that one, that'll be fine. And I've still not watched it, and our exam is in 23 days.
Oh, wow. Oh, wow, you guys have different deadlines to us. Than we kind of had an exam in December, which seemed really early. Nobody had an exam that early if they didn't go to Manchester for their uni placement. So yeah, interesting.
What was your exam in?
It was Intro to Healthcare Science, actually, and it was it was a multiple choice question exam, which was really strange, actually, because they really did cover every specialism under the sun, which I guess was a blessing now, because I just kind of think I've learned so much about other people's specialisms that I never would have known. But in terms of day to day, I mean, we did the female and male reproductive system, which could not be less relevant to critical care in the slightest.
Rotations. We do have a rotation repro, so I found that one quite useful, quite interesting. Yeah, but we also had lectures in like medical physics, and I was just like, I A, don't understand physics, and B, I don't know when I'll need to have a look at like a CT scan or anything. So, but, well. Cool. So what would you say to anyone thinking of applying to critical care this year?
I would say the best place to start to see if it's the specialism for you is on the curriculum library. I didn't realise this was freely available to the public before applying for the STP, but my God, what a good research. Like, you can see pretty much day to day what you're going to be doing in each rotation. It's so handy, and the academic content as well is all on there, which is great. You can kind of see if that's something you're interested in. Very luckily, having not read that, this was exactly up my street and what I wanted to do, but I know it quite could have been, you know, the other way around. So I'd have a look at that first, and then I'd also just get talking to other critical care STPs. I mean, I'm here. 6 of us currently training in our first year. And there's enough people to speak to. You can find them on social media, and just, you know, it's not a specialism that people necessarily know a lot about. We're still quite small, so it's all about talking to the right people and just making sure that this is going to be the specialism for you, because it's a good one.
Definitely. I guess because it's not something that you can really do like a degree in beforehand, so you can't test the waters and see if it is for you.
Exactly, yeah. And I think it's not an environment where work experience is readily available either. So you can't kind of spend a day on the internet. I mean, you couldn't do that before COVID, let alone now. It's like an impossible task to get visited in at the minute, for obvious reasons. So I think the best thing you can do is kind of focus on your transferable skills rather than your directly relevant ones, because you can always pull transferable skills out of the stratosphere from anywhere. I always think you don't realise how much experience you have until you really think about it. I'd say, just get talking to people, and anything that you can kind of relate back to the specialism isn't wasted. So,
Brill. Well, thank you so much for that. That was super interesting. I like seeing kind of background into something so vital at the moment.
Thanks for having me, though. It's been good to chat. I obviously want to talk. So.
Yeah, me too. It's nice to just have something to like change the day up with as well at the moment. I'll talk to anyone.
Yeah, and even if it's a chat about work, you know, it's a chat.
Cool. So have a nice rest of your day, and I hope everything stays okay and not too stressful.
Thank you very much. I hope it's going well for you too.
Thank you.
Thank you.
All right. Bye-bye.
Bye.